Yeah.
So, ladies and gentlemen, we're very privileged tonight to have Dr. Ladd speaking to us. He got a first in physiology at UCL, then went on to medical school at St Bart's Royal London, completed his postgrad training there, and doubly qualified in both acute medicine and intensive care. So we got two for the price of one. And he completed his training in 2014, and we were lucky enough to snaffle him in September. So Tanish's interests, clinical interests, include ambulatory care, point of care, echocardiography, and strategies to improve the flow at ED and the acute assessment units, which is what he's going to talk to us about this evening. So he sounds pretty perfect, except he's obsessed by football, so I was putting it down. And I'm really grateful to him for being here tonight, because he's got a 10-month-old son who's been properly poorly and only was released from hospital today. So it's jolly decent of you to still join us. Thank you.
Well, thank you for that warm welcome, Liz, and it's a real privilege to be talking to you about some of the things I've been working on at Basingstoke for the last 14 months or so. The title of this talk is From the Broom Cupboard.
You might need to go a bit nearer the microphone.
Oh. Can you hear me? Hello? No. So the title of this talk is From the Broom Cupboard to the Unit, because all really good ideas start from the broom cupboard. And over the next 20 or 30 minutes, I'll talk to you about how we made this journey. I'm on social media, so if any of you guys are on Twitter, you can connect with me during the talk, or after the talk if you have any questions. So as Liz mentioned, I spent most of my time in London when I was doing my training. I lived in a place called Bow, which is just east of Zone 2, which technically may be an East Ender, and some have said I've got a slightly Cockney accent. I'm not sure about that really. I enjoyed all the bright lights of London, and I frequently used to go there once I moved here. However, in 2014 I swapped this view for this view, including the View Cinema. This is a festival place, and that's a cinema I used to go to quite a lot. And also swapped that view with Winchester. These are the cobbled streets of Winchester, where I now live. Moving out to Hampshire has also meant that I have the ability to take really nice photographs. And this is some time-lapse photography outside my bedroom window. As Liz mentioned, I have a very young son. He has a habit of waking up really early in the morning before dawn, so I'll wake up and I look out the window and I get to see these lovely pictures. And these are just taken with an iPhone, so anybody could do this. And this is clearly the highlight of this talk. After this, it gets very serious. This makes my day a little bit more bearable when I wake up at 4:30. So let's get serious. I think Andrew has mentioned some of these concepts already. We've all read these sort of headlines recently. Breaking point. The government's bad for your health. Apparently the NHS is dying. It's the worst crisis. Long waits for ambulances. This is what the public are reading, and this hasn't come from the Daily Mail. This has come from the Royal College of Emergency Medicine, and they're reading figures like this: and 92,000 emergency patients were admitted to hospital in the same week, up from the previous week. 60,000 people visited A&E in a single day in December, up from 46,000. So pretty scary figures. Interestingly, this article is paired with this picture of ambulances apparently queued up outside one of our rival hospitals. This is apparently Queen Alexandra. Actually, this photo is wrong. This is actually an ambulance car park. This is not Queen Alexandra. But again, it creates this anxiety about what's happening in our hospitals. Although Queen Alexandra does have a large queue of ambulances apparently every room set. And then we came across this headline recently, which is a humanitarian crisis, which is what the British Red Cross has warned us about. And actually this is pretty frightening, because this is the sort of terminology that usually gets reserved for incidents that occur outside the United Kingdom. So this is all very frightening for people within the NHS and some of you guys who are patients. Is this all new? My wife isn't a medic. I have lots of friends who aren't medics. I have family members who aren't medics, and for the first time this year they've said, oh, this is really bad, what's happened? And actually this isn't new, is it? Because if you look at this graph, this is the number of emergency attendances to A&E since about 2004. This is when roughly the 4-hour rate came in. These are the total attendances, and you can see they're gradually increasing. That's also reflected by this graph. This is the total number of patients who are waiting in ED for over 4 hours, again reflecting on what Andrew had said earlier. Patients waiting in ED over 4 hours after a decision to admit decision has been made, and this is from 2010. You can see the trajectory is like this, and you can see these peaks. And these peaks aren't coincidence because they're seasonal. They're occurring in winter every time. And of course 2015 was really bad. That was my first 2015 winter was my first time as a consultant at the Trust, and it was arguably the toughest I've ever had as a doctor. It was really stressful, A&E is really tight, beds are really tight. And it'll be interesting to see what happens in 2016. I'd imagine it might be somewhere around there. So traditionally, certainly for acute medical presentations of illness, the traditional model is that you happen to go to your GP or you happen to go to ED and then a decision is made or discussion is had between that doctor and a medical decision maker in hospital. And then a decision is made for that patient to come into hospital to be assessed for their acute medical needs. And that usually occurs in A&E, on a trolley, or it may occur in our medical assessment units, or we call them AAUs, in Basingstoke, and that occurs in a bed. Okay? So we looked, or certainly the Royal College of Physicians, looked at something which we can do differently to try and make that process a bit more efficient. And they came out with this. It's a toolkit in 2014 describing something called ambulatory emergency care. And this is how they defined it. They defined ambulatory care as clinical care, which includes diagnosis, maybe a bit of treatment, some observation, maybe some rehabilitation, which doesn't occur in a hospital bed, doesn't occur necessarily in a hospital trolley in A&E, but doesn't really occur in outpatients either. It occurs somewhere in between. And a simpler way of looking at that is essentially this is same-day emergency medical assessment, treatment, and discharge home, plus or minus any follow-up. What are the perceived benefits of this way of doing things? Well, the idea is that by having this separate work stream, you can divert maybe 20 or 30% of all emergency patients via an ambulatory work stream, not via ED and not via the acute assessment unit. Clearly that can impact flow within these areas. It might impact the 4-hour target. And also patients might prefer this way of being looked after, because I think generally believe patients don't want to be in hospital unless they absolutely have to. And taking a surgical example, this is essentially day case surgery for medicine. I think Andrew mentioned gallbladders, I think, earlier today. 15, 20 years ago, if you had a gallbladder problem, you come into hospital, you get admitted on Monday, you might get starved on Tuesday, you might be operation on Wednesday, Thursday you might think about getting out of bed, Friday you might go home. Nowadays, if you have a gallbladder problem, you come into hospital, you have the gallbladder taken out at 1 p.m, you're home by 5. And it's that way of slightly being less risk averse for medicine. And that's essentially what this is. So at Basingstoke, what did we do sort of pre-2015? Our service was a bit like this old car. It's an old Ferrari, so not a bad looking car, but it needed new tyres, it lacked a couple of wing mirrors, the windscreen's dented, the bonnet needs replacing. So we needed to upgrade this Ferrari into something a little bit more spectacular. We had an informal service, there was no referral pathway, and because our referral pathway because we didn't have a referral pathway, our numbers were quite small, and we weren't able to record data as well as we should do. We also suffered in terms of this. It's called the best practice tariff, and essentially this is a way of incentivising hospitals and trusts to manage certain emergency conditions the same day. And if you do that, then you would be financially rewarded. So for example, low-risk chest pain, pulmonary embolus, cellulitis, all of these things, if you manage to treat them the same day, the trust gets rewarded. And because we weren't doing this as well as we should do, we were suffering from this. We had some concerns because some patients had expressed some dissatisfaction and there was no dedicated area to do this. So what do we aim to do? We aim to get to this sort of Ferrari, maybe the sort of car Andrew might drive at the weekend, I don't know. Something a bit shinier, something a bit faster, something a bit slicker. So what do we aim to do? We wanted to reduce medical admissions. We wanted to stop stable medical patients being admitted into a trolley, into A&E, or into a bed on AAU. We wanted to try and reduce the burden of work on the on-call teams. We wanted to improve patient experience. And we wanted to improve something called this best practice tariff. We wanted to standardise the process. We wanted to accurately record this activity so we can communicate with GPs and other secondary health providers. And we wanted to create a virtual ward so that if you discharge patients on the same day, we would have a system in place that we can follow them up, make sure the scans are done, make sure the bloods are tested, and provide that sort of safety netting that we can do if we discharge patients early. So we had phase one. So how do we do this? I was relatively interested in this process. We had some trainees who were also motivated. We spoke to some nurses, we spoke to some radiologists, some bug doctors, people who make up drugs, business intelligence, and IT. So we spoke to all those stakeholders, and we started making some progress. So we started recording some activity on EPR. This is our hospital electronic system. And so actually what we do now is everything is electronic. We are a paper-light system. We created some leaflets for patients, and we created a post-box system where we can refer patients who don't need to come into hospital, but we can provide a system where they can be seen the next day. We acquired a so-called broom cupboard, which is an AAU, and this is one of our trainees who's working very hard. We went live in December 2015, and these are our initial results. So we saw an average of about 40 or 50 patients per month, Monday to Friday, 9 to 5. We saw quite a lot of follow-up patients, and these are patients who were discharged early from AAU with early follow-up in ACU, so we can have the scans checked, we can make sure they're clinically stable, make sure the blood tests are done. There are some peaks here, 62 patients here, 75 patients here. These are patients who were coming in for regular antibiotics intravenously, and by being ambulated, they didn't have to be in a hospital bed to do that. They came in, had their antibiotics, and went home. The real money, though, is in this group, new patients. So these are new patients who ordinarily would have gone into A&E or AAU, and we're now seeing them through ambulatory care. And we saw roughly about 20, 25 patients a month, which is not bad. But if you break this down, that basically means one new patient a day. So not bad, but some room for improvement. And actually, we did encounter some problems. That broom cupboard's quite small. We didn't have dedicated space, and therefore we're unable to expand numbers. And if you can't expand the number of patients coming through our ambulatory service, you can't impact on A&E, you can't impact on the medical admissions process. We also created some overcrowding in the AAU waiting area because the ambulatory care room was in the same room as the acute assessment unit, and so there's confusion over who owned which patient. So some problems to think about. However, we did present our data at the Trust Quality event. We won this award on the basis of some of the data we presented. This is one of our trainees who was involved, and this is Julie Maskery, who's I think a transformation manager. And this was quite really important for us because we got recognised, we got some publicity, and all of a sudden people started asking us questions about how they can help us. And that was really important in terms of widening that stakeholder engagement. So this led to phase 2. Similar sort of stakeholders were involved during phase 2. And through some discussions with various colleagues, we were able to acquire a slightly bigger space. So this is the bigger space, which is just next to AAU. So through this window lies the acute assessment unit. This is at the back of our short stay ward, on the emergency corridor, so we're close to A&E, we're close to EAU, we're close to radiology and all those important places you like to be placed at when you're presenting into hospital. We have a small waiting area. There's some more chairs out here. There's 2 assessment chairs, so we can assess patients and treat them. And there is a little doctor's desk and a drug cabinet. Our receptionist sits here. And again, this is just another view. Importantly, we were able to get some dedicated staffing. I think this is the most important part of this process. We didn't actually recruit any external staff for this process. We just restructured existing staff rotas, which is, I think, very impressive for our nursing staff and our admin staff. So no additional staff, we just restructured existing rotas. So now we have dedicated nursing staff, admin staff, HCAs, band 4s. They're not usually this happy, they're usually pretty miserable, but they're happy in this picture. We've got some dedicated trainees, so these are some of our GP trainees who really enjoy working in ambulatory care, because it's like being in primary care with a bit more. So you have access to diagnostics and blood tests. These are some of our core medical trainees, some of our medical registrars, and these are actually tweets which are sort of promoting our service, and we're quite active on social media in terms of some of the work we do. We have 2 dedicated trainees who come on a week at a time, and they cover the unit between 9 and 7, Monday to Friday. So we went live the back of September last year. The way we did it was, if you happen to be a GP, say a GP in Alton, and you visited your GP and you clearly had a medical problem that needed assessment, but not necessarily a long period of time in hospital, you could talk to your GP would talk to the medical registrar at Basingstoke, and provided you can attend between 9 and 7, your observations are relatively stable, you can make your own way, you're most likely to be discharged the same day. We'd say come to ACU, not AAU. Out of hours, we have a system where, for example, if again, I'll use the GP example, if you happen to be a GP, you're seeing a patient at 9 p.m. on a Monday evening with an acute medical presentation of illness, we could wait till the next day instead of coming into a hospital bed and waiting 10 hours. We have a system in place where we can see you the next day, and it's robust enough for us to be able to do that effectively. We have some pathways for cellulitis and PE, which I won't bore you with, but we have a couple of pathways. We operate a process-driven pull system, so we'll try and generate as much work for the ambulatory unit as possible. I think our mantra is everybody's suitable for ambulatory care until proven otherwise. If you happen to be 90 or 18, if you can walk, if you've got an acute medical presentation of illness and your observations are stable, then you should come to our ambulatory care unit. We work between 9 and 7, depending on our staffing. And we are in close proximity to the acute assessment unit, which is quite important for me because although we had dedicated staffing for all of the facets, at that time I was the only full-time consultant there, so I needed to be in a place where I could cross-cover both the acute assessment unit and the ambulatory care unit. So how do we get on? And you can see this is what we were doing at the broom cupboard, and as soon as we went to a dedicated space with dedicated doctors and dedicated admin and nursing, the number of new patients, which is where the real money is, has gone up. So we average roughly over 100 new patients per month, Monday to Friday, 9 to 7. We see a total of about 160, and we still have our follow-ups. But this is where the money is, because these patients ordinarily may have been admitted to a bed or admitted into an A&E work stream. And what we're trying to do is create a system that relieves the pressure on those acute areas of the hospital. This is a graph that shows that a bit better. This was broom cupboard, low numbers. This is dedicated unit, higher numbers. Okay, so lots of new patients and follow-up patients. Where do our patients come from? Predictably, most of our patients come from general practice. So when we first opened up September and October, the blue represents general practice referrals. The majority of our patients did get referred from general practice, which seems sensible. But interestingly, as the winter kicked in, as our A&E became more fuller, as the number of patients in ED became larger, we started pulling more patients out of ED. into ambulatory care. And you can see actually it flipped in November, December and January. We were pulling more patients from ED into ambulatory care. For February, this is reversed, and that might highlight the changes that Andrew described, and just and a bit of luck, I'd have thought. We also started seeing patients from other parts of the hospital, so we've had referrals from fracture clinic, we've had patients from diabetes clinic, and other ward referrals who are coming into ambulatory care. The purple represents the number of admissions for ambulatory care, which is about 7%, and that's in line with recommended national guidance. So what sort of stuff do we see? This is what we've been told we see. We see a lot of chest pain, a bit of breathlessness, headaches, chest infections, PEs, arrhythmias, skin infections, collapses, and again a bit more chest pain. The sort of things you expect to see in an ambulatory environment. But we don't just see those things, we see a wide variety of things. We see liver disease, we see skin problems, we see cardiovascular problems, muscular problems. So on this list here we see quite a lot of things, and I think that probably represents why we don't have rigid pathways in terms of the patients we see. Everybody's open to coming into ambulatory care. In fact, we've even had some non-medical presentations. I think we've had orchitis there. That slipped in. That shouldn't have come to us, but again, if it comes to us, we'll manage it.
I'm guessing most people won't know what that is.
That's sort of inflammation of the testicles, which isn't a medical problem. Well, it's a surgical problem, a urological problem. So yes, it's but we've managed that. I said earlier on about how we impact the best practice tariff, because this creates revenue for our department or the trust. And these are some of the common conditions that we see through ambulatory care, as I described: cellulitis, skin infections, chest pain, headache, anemia, asthma, chest infections, falls, and clots in the lung. This is the target. So for example, for clots in the lung, PEs, we have to achieve 18% of those patients that go home the same day. Chest pain, for example, 50% of our patients should be seen and discharged the same day. Before 2015, so if you think back to that old Ferrari, we weren't doing very well. In fact, the red means we weren't meeting its targets. We were doing okay for chest infections, we just crept over the target. Chest pain, we just crept over the target. We were pretty rubbish at everything else. And then we went to the broom cupboard and we started getting better. So we started hitting these targets. And then now we're in a dedicated unit. We're not only meeting most of these targets, but we are actually exceeding those numbers quite dramatically. So for example, for clots on the lung, we're expected to see 18% and discharged on the same day. We were at 15, we scraped through onto 19, into the green with the broom cupboard, we're now at 40. Anemia, for example, we're at 16, we scraped through at 17 in the broom cupboard, we're now at 40. So we're doing a lot better. Asthma, we're still working on. I think the problem with asthma is when most patients present to GPs with asthma, many of you might have asthma, usually those patients are initially quite sick until they receive some therapy, and usually they end up going into a A&E or an AU work stream. So we're getting better. How do we impact on the medical admissions coming through the hospital? So this is quite a messy graph, but generally speaking, you can see it kind of goes like this, and it dips here. Ambulatory care got set up here, and you can see there's a little dip in terms of the medical admissions coming in through the hospital, because a lot of those patients are being siphoned off to the ambulatory work stream. Predictably, as winter kicked in, there was an increase in the medical take, or the medical admissions, but in February we started to see another drift down. So it's all very well having really fancy data, but what do our patients think of it? So we did a survey of 100 patients, some feedback forms. 5 is excellent and 1 is poor. How many were satisfied with the waiting time to be seen by a doctor or a nurse in ambulatory care? The majority were 5s, 4s and 3s, so maybe a little bit of room for improvement, but generally most were 5s. Were you happy with the care you received? Again, most of you rated it as excellent. Were you satisfied with the information? Generally, again, the majority were 5s, excellent, or 4s, very good. And how would you rate the service? And I'd like this to be a lot bit bigger, but it's essentially excellent and very good. These are some of the comments that have come through, and usually I think these comments are very important because they provide some motivation and it keeps our staff very enthusiastic. And you can see there's some themes that come up. People were very complimentary about the team and the nursing staff. My favourite here is impressed to be offered a sandwich at lunchtime because we don't usually offer sandwiches. So I'm not quite sure where that comment came through, but generally this is very nice. Our nursing staff have also been complimented on their activity. This is a letter from Donna Green about our ambulatory care nursing team. We've been invited to an award ceremony this summer. We've also had some compliments from Customer Care and PALS. This particular letter is about some of the nursing staff, and Alison is one of our GP trainees who's working locally, and her activity in the ambulatory care unit.
Purple category.
I don't know. I don't know. Do you know what purple category is? Very good, I think. I'm being biased. This is on the staff Facebook page. Again, this lady was very complimentary, and actually the picture here is us, some of our team members at an ambulatory care networking event, which I'll tell you about later. I've also had some personal experience through ambulatory care, not the ambulatory care that we've set up, but paediatric ambulatory care. This is my son. He's 10 months old. He's usually very happy, but about 4 days ago he was very ill and got admitted to hospital with sepsis and pneumonia, and he was admitted for a couple of days into the hospital at Winchester, and he needed intravenous antibiotics. He got better, but not quite well enough to go home, but wasn't quite ready to, but didn't quite require a hospital bed. So he was ambulated through their ambulatory service, and so he came home yesterday, and he'd go back into hospital to have intravenous antibiotics once a day. And this was really good because he gets to spend time playing with his toys, like this thing here. He doesn't play the guitar, but he uses it to stand, and he can spend the night in his own cot. He can play with his own food. He doesn't have to have hospital food, and he goes back once a day to have antibiotics. And in fact, he was discharged today, and he goes in every day for the rest of this week getting intravenous antibiotics. So I can only, that was a paediatric service, but it works out very well. It's worked out very well for us. Recently, we recruited another consultant who's sat in the room. His name is Vas, and we're very lucky to have him. And as soon as we recruited him, we changed the way we work on ambulatory care. So we started, whenever there's 2 of us or 3 of us, Dr. Singal is also one of our colleagues here, we try to have a dedicated consultant in the ambulatory care unit, and we work longer hours. And we try to measure this over the month of January, and the idea was that, the feeling was if you have a dedicated consultant, if you have consultants working longer hours, we'll see more patients through the ambulatory care stream because we can siphon off and pull more patients. And although this is a very small sample, you can see the orange is when we had a dedicated consultant working longer hours. And generally speaking, when you have a dedicated consultant, you'll see 2, 3, maybe 4 more patients. These are all new patients. This doesn't even include follow-up patients. We've now continued doing this into February, and we found that if you have a dedicated consultant, we would take away maybe 30% of all the acute medical presentations onto the medical admission team. When we don't have a dedicated consultant, we would take away 20%. So is it all a bed of roses because I've just told you all the good things? No, there's a few things we can make better. Space is an issue, so although we have a bigger footprint, we only have 2 assessment seats or chairs, and we have 1 trolley. So if they get full, then with patients receiving intravenous therapy or some observation, then we limit the number of patients that come through ambulatory care. We've had some issues with staffing. It can be variable. Recently we had some problems with making sure there's consistent staffing in terms of nursing personnel and junior doctor personnel, and actually once it has led to us stopping the service for a day or 2, which is not something we want to do, but to ensure its safety we've had to do that just the once. We want to make sure we have a quicker turnaround time from radiology, so once you get your scans, we want them reported and fed back to patients as quickly as possible. We're working with pharmacy about how we get your drugs on discharge quicker. And we do have some variability in our operational hours. Recently, we've been open until 5, again because we've had some staffing issues instead of 7. And there is variability in the consultant model because when all of us are here, my consultant colleagues then will operate an extended service. When we can't do that, it becomes a shorter service, but I'll talk about how we might change that. And some of those comments are reflected by some patient feedback. We don't just get good patient feedback, we get some constructive criticism. And it follows those themes I just mentioned. Not enough room, quite a small corridor, need more consultants, medication took a bit too long, scan timings were a bit too long, more nurses and doctors for a quicker service. So what does the future hold? What does phase 3 hold? So this is something that we're going to continue to do. We've recruited another consultant who started with us. And again, what we're trying to do is having a dedicated acute medicine consultant in ambulatory care to try and work extended hours, to try and help the on-call, try and help the pressures in ED. Hopefully we can try and move to a bigger footprint, because I do think we can see at least another 5 to 8 patients a day for ambulatory care if we have the space. And also, I think all GP phone calls should be coming through to the acute medicine consultant in ambulatory care. So having a dedicated hotline, I think would be beneficial. And this is some work, there is some work I've done on this. About 1.5 years, 2 years ago, I took all the GP calls for a period of time and measured my activity or my performance with the registrar taking phone calls. And the results were, well, I think it kind of makes common sense, really. This is the raw data. This is the registrar taking phone calls from GPs. This is me taking phone calls from GPs. And generally speaking, I would defer more patients back to the GP with advice compared to the registrar. So I would defer 23% back to the GP. The registrar would defer 11%. For those patients I accepted onto AAU, because I'd taken the phone call, I knew about the patient, I could plan their arrival onto AAU, I was able to discharge more than the registrar. We admitted less. Also, what was important is that we measured how productive the on-call junior doctor team was with me taking the phone calls. So when I took the phone calls, at times of handover, there were less patients waiting to see a doctor compared to the registrar. And again, that makes common sense, because if the registrar's taking phone calls, then he or she is less productive in managing those patients. And that's probably easier seen on this graph. So I'm in red, the registrar's in blue. So the consultant deferred more referrals, discharged more patients, admitted less, and there are less patients waiting to be seen by a doctor at times of handover. So we published this work. This was it was published and we presented it at a conference in Belfast. This is one of our trainees. We presented our data, and if any of you guys want to see the reference, I can forward that on to you, or I can tweet that to you. So certainly we're definitely looking to try and do that in the future. Recently we've had a business case for a point-of-care blood test machine to be trialled on our unit. So the idea is that this can turn around blood tests within 15 minutes, and that can make the flow through the unit a little bit slicker. We want to aspirationally divert maybe 30% of sort of medical presentations of illness through the ambulatory care work stream. We want to develop a nurse practitioner role, and ideally maybe even have a clinical fellow situated, or a permanent doctor based in ambulatory care to provide that continuity to stop the variability in junior doctor staffing. We're also part of the Ambulatory Emergency Care Network, and we're actually profiling our work nationally with this service. And in fact, they've actually got one of our tweets on their homepage, and we're promoting the service nationally, and we're due to present to them in May. None of this works without the team, and these are just a subgroup of people who make this service work, but there's lots of people here who aren't in that picture who've been really outstanding in making this all work. And finally, a lot of people in the room here are responsible for clinical change or instigating changes of behaviour within hospital or primary care. And I have some principles for leading change, and I think you should all think like this guy, think like a farmer. Don't shout at the crops, don't blame the crops for not growing fast enough, don't uproot crops before they've had a chance to grow, choose the best plants for the soil, irrigate and fertilise, remove any weeds, realise outcomes are not predictable, and sacking the farmer won't help the crops grow. That's it. Thank you.